So with that being said, we are going to go on to the last slide. And I did also promise you earlier that we were going to talk a little bit about money. We know that, most folks, it's easy to, quite frankly, understand the problem that's out there with the diabetic population in this country. It is easy to get behind something that is going to help those folks. But at the same time, you all have to look at it from a business perspective to some degree. And so there needs to be some financial benefit there, or at least financial justification to be able to move forward and provide this. So we wanted to certainly talk about that a little bit. And I'll let Chandra go ahead and talk about their experience, and then I'll bring it back home with some final comments, if you will. So Chandra, I'll let you take away on this.
All right, thank you, Tom. So for Community Health, being a federally qualified health center, we are able to bill out Medicaid and Medicare services at an enhanced rate. And what that is based on our uncompensated care, our cost per medical visit, that rate is set each year. The purpose of an enhanced rate is so that we can take the additional dollars that we're able to bill for those services and put it into our charity care or uncompensated care programs. So just as a reminder, one of the earlier slides, about 22% of our patient base are people without health insurance coverage. So the ability to have an enhanced global rate creates the opportunity for us to offer the same level of services for our uninsured patients. Also, having the diabetic retinal scan available for our diabetic patients, it helps to close some of those care gaps that the managed care organizations look at in terms of incentive payouts or packages. So when we're able to close that metrics, it certainly adds to our score and our ability, our eligibility for incentive payouts. Additionally, we are able to incorporate the scan into a comprehensive medical visit. And when we do so, it is eligible for that enhanced rate of reimbursement or that larger global rate that I was speaking of. But I would say probably a good example, and this played out this last year, is positioning us in negotiating with payers. So in the Panhandle of Florida, Region 1 is the four western counties. And in Region 1 in Florida, a managed care organization was bought out. So when that company came in, it was an opportunity for us to sit down with a new payer, look at our contract, and negotiate. We wanted a capitated contract. And we were able to show them that we are a true primary care home and that we have this large spectrum of services that are available for our patients. And with that in mind, we were able to negotiate an increased rate in our capitation to the tune of an additional $7 per member per month. And when you're looking at 15,000 members that are assigned to you, that additional enhancement in the capitation rate certainly improved our cash flow position and certainly helps to support all of the other programs, support programs or wraparound programs that we have to support our patient base. But I'd like to just close out this slide or kick it back to you, Tom, just by saying having the program embedded within our primary care home and service site. My office is literally located down the hall from Dr. Charbonneau and her team, and I see our patients coming in each and every day. And the ROI on just the patients leaving happy, pleased, cared for, they're going out and they're sharing with their friends and family how they can go to this one location, see their physician, but also see their eye doctor, also get their medication and all of the other services that we provide. So being able to add that additional service to our spectrum of services has improved our patient satisfaction, has obviously played well for us in quality and incentive payouts, and certainly just adds to our position when we sit down with these payers and negotiate our rates.
That's fantastic. That's so good to hear. We at Iris wake up every day and think about literally ending preventable blindness, and how do we expand this program, and having a partner such as yourselves that have found a way to make it work, that are really a great example of the benefit, as you say, of offering that whole package. And it's just dynamite. So one of the things that I wanted to address is that I know that not everybody that may be on the line today, or that may listen to this recording afterwards, are part of an FQHC. Some folks were just interested in Iris and the program, and certainly, their situation may be different. And I kind of addressed it earlier in the presentation that we really encourage all of the folks that we're speaking with about potentially coming on board with the program, to consult with your own reimbursement folks. Everybody has a different situation. Their payer mix is different. The types of contracts that they belong to are different. Their government classification is different. And so generally, what we find is that there's a number of kind of different buckets where people find, to various degrees, based depending on what kind of provider you are, and depending on what kind of contracts you're in. But there's really some different buckets that provide ROI. And by the way, this addresses, I believe, one of the questions that came in on the QA. Not surprisingly, two of the three that I looked at so far had to do with reimbursement. So we know that it's an important piece of the puzzle that needs to make sense in order to be able to provide this service to your patients. So anyway, so just in general, again, these may apply to different folks more or less depending on your contracts, but generally, and sometimes there's kind of an upfront, we call it a fee-for-service reimbursement, typically involves using a particular CPT code. There's a number that different CPT codes that our clients use that may apply depending on their interpretations of the codes. 92250 is one. 922227 is one. I think I used too many twos there. And 92228 is another. But again, depending on your environment, those may or may not work according to your interpretation. But typically, there's a reimbursement up front for that service. Depending on which code you use, there are technical and professional components to those codes. So we have some folks that bill a global and bill both. Two of those codes are only technical pieces, but we can get into those discussions individually in more detail. But one bucket is that fee-for-service reimbursement. Another area is in general quality scores being improved. And Chandra kind of mentioned this in her organization. Depending on whether you are judged by HEDIS scores or other metrics, NCQA or whatever they are, certainly having a higher percentage of your diabetics having an annual eye exam certainly improves your metrics and improves the opportunity for whatever your arrangement is, whether it be bonuses or whether it be excess financial benefit that comes back to your practice or your clinic or your organization based on having those higher quality metrics. Obviously, that's incredibly important. Another area is an area that I mentioned before, and that is in the area of risk adjustment factor type contracts. So those contracts that reimburse based on a PMPM basis, and then based on the acuity of those patients, that PMPM number may rise or fall based on that acuity. Certainly identifying folks that are diabetic increases that PMPM. Identifying diabetics with eye pathology increases that PMPM even more. So really, it's a matter of being appropriately reimbursed for the care that you're delivering for your particular population. The last one I'll kind of talk about is the last big bucket, is really in any of those contracts where you're assuming a great amount of risk and are responsible for downstream costs. Obviously, as with almost any disease, the earlier that you can catch it, hopefully the less invasive and the less expensive that treatment will be to either keep that pathology or that disease at bay or help to improve upon it. So if we can catch folks earlier, we're avoiding those downstream costs of catching that pathology later, of them going potentially, functionally blind, that increases the cost of caring for that patient dramatically, obviously. So if we can avoid those costs, that's kind of another area where people look at in terms of reimbursement. And then the last that Chandra mentioned was in having this as a service and being able to use that as a negotiating tool can be critically important. So a number of different areas. Obviously, you may have a specific situation that would love to talk individually